The next model we're going to talk about is the sociocultural model, right? And when we think of what drives mental illness, abnormal behavior is looked through the prism of your social factors, your environment, and cultural forces. And these sociocultural factors impact who we are. Now, when we think of the sociocultural model, a lot of the research started in sociology and anthropology about in groups and out groups and group differences and the role of the social environment impacting the person. So what we suggest is that in addition to taking the history of the person and their suffering, you also have to examine the environment or their social surroundings to fully understand psychological distress. So let's take a look at some of these factors. So you might focus on the family, right? So the family structure and family communication. When we talk about family systems theory, we believe that dysfunctional behavior in the family leads to dysfunctional behavior in the individual. So there is an understanding that a toxic family environment could impact one's mental health. And we say, and I might have used this phrase in an earlier video, I'm not sure, insane behavior becomes sane in an insane environment. And I put insane in italics, so I'm not labeling it. It's just so that you recognize the power of the environment. Now, families are meant to have firm but flexible or some flexible boundaries between one member of the family and another. But it is possible that in some families, these boundaries become very blurred. And there's something called an enmeshed family style, in which one member of the family becomes overly involved in another person's life, to the point where it's possible that this individual is weighing in on who the person dates, maybe weighing in on the jobs they take in a way that's not meant to be helpful, but it's over the top, not allowing the person to discover themselves and who they want to be with. The opposite is also true. So you can have people who do boundary crosses, but you can also have people who are detached. And we have a disengaged family style where the boundaries are so rigid that one person doesn't approach the next. So I'm sure some of you in this room might have a parent that says, well, why are you wearing those clothes? Why are you doing this? Why are you doing that? On simple decisions that they don't need to weigh in on. That might be an enmeshment. So we also have to understand the role of culture, right? So one of the criticisms that Thomas Saz said, and I think I said this in our first lecture, is that the definition of normal and abnormal is very much culturally dependent. And how does the culture view normal and abnormality? And what is considered normal and abnormal? You have to know what's going on in the culture. Another important thing is social networks and social support. We all need people. One of our understandings is that human beings are what we call a social animal. We require relationships. And people who have very limited social support networks can struggle with abnormality. And I want to talk a little bit about loneliness, because there are two kinds of loneliness. There was a researcher by the name of Dr. Weiss. Dr. Weiss noted that there are two kinds of loneliness. There's a social loneliness or alienation, and then there's an emotional loneliness or alienation. When we talk about social alienation, it's exactly what we're talking about on this slide. People who have underdeveloped social networks. So they're struggling, but they don't have anyone to go to. Maybe their family shuns them, doesn't give them support, or is overly critical. So they can't go to them. Maybe they don't have sufficient number of friends to talk things through. Now, you don't need a massive social network. 3 good friends would be the goal. But there are people who don't have 3 good friends. They have a lot of acquaintances, they have a lot of people on their cell phone, but not 3 people that they know they can count on. So when a person struggles like this, we're going to refer to that as social alienation. They don't have the social support. But there's an emotional alienation where a person might have tons of people around them, but still feel alone. So you can see, sometimes we see people who die by suicide. Sometimes they had a lot of people. You might say, oh, on social media that they had so many friends, they look happy all the time. How could that be? The answer is simple, because even with all those people around them, they still felt alone. So having a healthy social network that you can tap into and feel part of is important. And then societal conditions like financial resources matter in terms of mental health. I said to you earlier that mental illness targets all people, regardless of whether you're rich or poor. But that doesn't mean that it happens all the time at equal rates. And there's this downward drift hypothesis. Now, it's a correlation between lower socioeconomic status and mental health problems. And you could argue that the mental health problems cause the deterioration of financial resources, but it also goes the other way around, where a person starts with limited financial resources, and that serves as a stressor that leads to some form of abnormality or psychopathology. But we still have to pay attention to labels as well, or stigmas. Now, there is this cool research study that Rosenhan did in the 1970s, and it's still applicable. Now, what Rosenhan wanted to demonstrate was that when you put a label on a person, they tend to be treated differently in society. So again, you could see how labels impact attitudes towards a person. Well, what did Rosenhan do? Rosenhan had several of his grad students pretend to have schizophrenia so that they would be admitted to an inpatient hospital. It was by design. And then what Rosenhan said was, as soon as you're admitted to the hospital, I want you to return your behavior to normal. And let's see how long it takes for them to realize that there's nothing clinically wrong with you. And what's interesting is Rosenhan had to get these students out of these institutions, because once that label was put on, it was very hard to remove. And even normal behavior were viewed abnormally once the label was put on. So naturally, this is a research study. So Rosenhan's students would take note daily of their experience in this inpatient hospital. And those notes were for research purposes, but the note-taking behavior was viewed as abnormal, as some kind of pseudomanic or pathological behavior. Walking, when you're on an inpatient unit, there isn't very far you can go. So people might have paced a little bit, and the pacing was viewed abnormally. So what's interesting is labels alter how we view people. what's the end of the story? Rosenhan eventually got his students out of these hospitals, but on discharge, they were labeled as schizophrenia in remission. They never took the label off. They still kept it, not willing to admit that they misdiagnosed and hospitalized improperly, which Rosenhan took offense to. And he did a subsequent study where he took people who had existing diagnoses and had them behave normally to see if they would miss the fact that they were struggling with a diagnosis. And once again, they missed that too. So labels are powerful. Even things like saying this person is gifted. If you are a teacher and you get a student that's labeled as gifted, it's possible you're going to treat that student differently than other students in your class. How so? You might ask them more challenging questions. And as a function of that, sharpen the critical thinking of that child. So we have to be careful with labels. And labels come with a lot of stigma. So it remains this way today. So let's talk about some sociocultural treatments. So we talk about group therapy. We talk about individual therapy, right? So individual therapy, it works. You can talk about sociocultural factors in personal therapy. You can have group therapy targeting some kind of social issue. Now you have, usually it's about 6 to 8 people. That's a good size for group therapy, who are struggling with a similar issue. And they're working off of one another and processing it together. Now, the group therapy is led by a licensed mental health professional, and sometimes it's co-led by several mental health professionals. And as a function of that, the therapeutic process works. We also have group work that does not include a therapist. So self-help groups, we talked a little bit about Overeaters Anonymous, Narcotics Anonymous, any of these self-help groups, they don't require a therapist to help work on the issue. So the only difference between group therapy and self-help groups is whether or not you have a licensed clinician helping you work on the issue. We also have family therapy. Now, we talked about boundaries and things like that, but family therapy, the goal is to try and meet all the needs of everyone. And in order to do that, you have everyone come in. You take a genogram and map out the family. You invite every person to share what they believe the problems in the family are. And then you start working on either power or communication. Structural family therapy, the focus is on changing the power structure in the family. Now, if you were raised in a very traditional household, you may have some carryover that the man is the head of the household. They have the final say. Well, if that isn't working for the family, we might work with the family and ask, okay, can you yield some of the decision making? Can you give away some of the power that the family has put on you? So that's one of the things we do is in couples work or family work, we try and figure out who has more power and encourage the person with more power to give some away so that it feels more balanced or egalitarian, and that will smooth some of the problems in relationships. We also talk about communication, right? So conjoint family therapy works on communication styles. When you look at families that are struggling, it is oftentimes that people are yelling at each other, talking over each other, not taking perspective of the experience of other people in the family. People are scapegoating one another. There are a lot of these communication styles, and we teach people how to hear one another. So we might encourage what we call as perspective taking. A person from the family says, I'm experiencing ... And then we ask another person in the family to describe what that person might be going through on a deeper level. And as a function of that, they get greater insight. We also stop the verbal attacks or talking over people. So we encourage a healthier communication style. If couples therapy, again, couples, sometimes it's referred to as marriage and family therapy, but couples therapy is where we're working with two people who are in a romantic relationship, who have a long-term bond. And in relationships, one of the biggest fights people argue over is behavior versus personality. If something is behavioral, we engage in behavioral couples therapy. We encourage there to be behavioral change. So if, let's say, the couple is fighting because one person's not doing the dishes. Well, doing the dishes is a behavior that can change, or another person's leaving their shoes around the house and not putting them away. That is a behavior. You can work on that and encourage a person to modify their behavior for the unity purposes. But there are other aspects of who people are that are never going to change. So when we try and figure out personality, and let's say a person's more introverted and you're extroverted, and you're like, well, why don't you like coming to parties with me? Why are you so quiet? Well, you're fighting against that person's personality, and they're not going to change. So integrative couples therapy is teaching a person to embrace or accept the whole person, the person with their flaws, the person with the things that are not going to change because it's part of their core identity. I see something in the chat. Oh, okay, someone said they have to step away briefly. All right. So we talked about family work, we talked about group work, we talked about couples work. We also have to talk about community-based models. Now, community treatment, here's where you are attempting to alter the setting, the environment people are in, and try and predispose people for success. So I talked to you about the prevention models, but I'll talk to you as we go. So primary prevention, the goal is to address a problem before it exists, right? I gave the scenario of DARE in elementary school. The assumption is people are not doing drugs yet. Secondary prevention, you're addressing it in its early stages. So having sex education in middle school or high school is useful in preparing people if they're going to engage in safer sex practices. And then tertiary prevention is trying to address things so that they don't become long-term problems, or if they're already a long-term problem, still trying to address them. So we talked about 12-step groups for that. So these are all sociocultural prevention models. Now, when we talk about working with a person, we also have to appreciate the value of culture. And we recognize that we cannot have a one-size-fits-all approach to therapy. Each culture has its own set of values and beliefs, and our job is to help the person live in accordance with their value system. So we have training on culturally appropriate therapy or culturally sensitive therapy, which is designed to help when working with minority groups or groups from different cultures. I'll give you an example. I was working with a older adult who identified as a Muslim male, and he was diagnosed with prostate cancer. And we were talking about the importance of treatment and some of the barriers he faced with treatment for prostate cancer. And his initial statement to me is, I am not going to get cancer treatment because it's against my religion. And I said, okay, tell me more about that. And he said, well, if I get prostate cancer, then that's going to interfere with my ability to procreate. Now, this gentleman had 9 children already, but that didn't matter. In his mind, he said he still wanted the capacity to procreate. And I am not an expert on Islam. So I said to him, listen, I don't know how to react to what you're saying because I am Jewish and I am not as familiar with Islam. But I'll tell you, in Judaism, the number one responsibility is protection of life. And if it means saving your life, that's the priority. But because it may be different in Islam, I want you to ask your imam. And he came back the next session and gave me an answer that did not even come across my mind. And that's the wisdom of his clergy member. So he came back and said, yes, you're right. My imam said that my life matters, and if it's life and death, I should get the treatment. But he also said that if I am still worried about having more children, I can sperm bank, which is to freeze his sperm through cryogenics. And that did not cross my mind, because in my mind, I was like, could I make that recommendation? Because it could be him spilling his seed. And in many religions, spilling one seed is a problem. But because his imam said, yes, you don't want to die of cancer. This is the priority. He actually got the treatment. And what I was most happy about was the recommendation the imam said that didn't even cross my radar, because it's important for him to follow the guidance of his spiritual leader. And I would have trampled all over that one if I didn't invite him to speak to his imam. And that's an important thing with culturally sensitive therapy, especially with religion. When people are highly devout, you have to understand that they're going to want to involve their spiritual leaders in their decision-making too. So giving that invitation to him saved his life. So that is a very cool example. And sometimes we don't get it right too. I'm going to talk to you when we get to the lecture on anorexia about, an error I made in diagnosis due to not being fully aware of culture. But I'll talk to you about that in another class. So we talked about understanding people's values, helping people live in accordance with their value system, providing culturally sensitive therapy so that it is supportive of the unique needs of the individual and their community. Now let's talk about gender-sensitive counseling. So one of the challenges that people face today is the power differential between males and females, even today. So women face sexism and whatnot. So gender-sensitive counseling, it started through feminist therapy, where it was kind of getting equality for males and females. And then it moved towards working to understand the unique needs of sexuality, so being part of the LGBT community. And it has broadened further and further to address the fuller spectrum of sex and gender. But every time a person is in a minority status, there are unique challenges. And one of the messages, for example, that women get, Western women get, is that if you are speaking up or assertive, you're considered, well, I don't want to say, there are negative labels. Whereas a male could be just as assertive and it wouldn't be that way. So it has kind of implicitly suggested that women shouldn't speak up. Well, that's changing. So part of feminist therapy also focus on assertiveness training. Speak about your needs. Speak up for oneself. Do not feel you need to be passive. And there's a lot of empowerment that goes into this. Now, if you look at all of the models, you have them here, and you have the cause of dysfunction, what causes mental illness, the level of research support for it. I didn't use this, but whether a person's referred to as a patient or a client, I tend to use them interchangeably. The role of the therapist, what their job is, the techniques that they use, and the goal, right? So if you're looking for a nice summary slide for everything that we covered on the different models in the previous videos, this is a good one. Now, I do want to wrap up with a statement about no singular model can explain everything. So most of us operate from an eclectic point of view. What does that mean? We're going to integrate multiple models. Because as I said, each model has its benefits. Each model is valuable in understanding some aspect of abnormal behavior. So it is possible to take some of the strengths of a given model and leave the rest. So if you were to ask me, well, how do I approach therapy? I would say my predominant orientation is a cognitive behavioral therapist, but I do incorporate psychodynamic and humanistic principles in my treatment. So these are the three models that I've blended together to make my unique approach to therapy. And every clinician is going to gravitate to some models over others. For example, I have some colleagues who, at the notion of using psychodynamic principles, would make fun of me. And that's silly, right? To say, oh, there's nothing valuable in psychoanalysis. It's just not true. There's a lot that's of value. And we talked about it in an earlier video. Maybe they don't find value, but I do. So you take some aspects of psychodynamic, some aspects of CBT, some aspect of humanistic existential, and I put it together. In graduate school, you're going to have courses on approaches to counseling, and you're going to get a lot more experience with what I'm talking about. And you will be able to identify through various exercises which orientation resonates most with you, which is really cool. And there are even worksheets that you can fill out to figure out what your theoretical orientation might likely be. You're also going to get a course on multicultural counseling, because it's important to understand how the environment and culture shapes how one lives their life and carries on through their life. So we do integrate different models. We do operate from an eclectic or an integrative approach. Now, most of us also use what's called the biopsychosocial model or you might hear it referred to as biopsychosocial spiritual model, in which when we're trying to understand some of the influences on mental illness, we acknowledge, yes, there are these biological factors. Yes, there are these psychological factors. Yes, there are these social, emotional factors. And yes, religion and spirituality can play a role too. We put it all together. And when we're doing our intake, we're paying attention to all of these factors of a biopsychosocial model. Now, this slide kind of gives you a perspective as to where we are today. If you were to look, about 30% of clinicians are eclectic. That is the largest theoretical orientation of the day, followed by cognitive therapy. So we talked about Aaron Beck and his models. We have pure behaviorists. We also have cognitive behavioral therapy, which blends the two. And from there, we have psychodynamic principles. So what's interesting is that if you go to graduate school, you're likely going to be trained heavily on a CBT model, or if you have a historical or legacy-based clinical program, you might be trained in a psychodynamic model. There are still other models out there that you can get training in. And the good news is, even after you finish and get your doctorates, you have the opportunity for respecialization and further training. And for the rest of your life, you're going to get more and more training. But this is roughly where we are as a clinical body and our theoretical orientation. With that, I'm going to stop, and I'm also going to stop the recording. All right.